So welcome to our last visiting professor grand rounds before graduation. Of course, today's visiting professor is one of our own alumnus who's been incredibly successful and accomplished in a very short time in his career. We're very proud to have MaCalus Hogan back as our speaker this morning, as this is part of our Diversity, Equity, Inclusion lecture series. I would like Dr. Dacus, our Vice Chair for this area, to introduce Mac.
All right. I don't usually write notes, but Mac's pretty accomplished, so we kind of had to do that. It's always a pleasure to welcome back one of your own. When I started, one of the reasons I came here was because of the resident group at that time, and Mac was a part of that. He was also a classmate with Dr. Guafni, and a lot of you residents don't realize that we talked about it last night, that weekend rounding is because of he and Dr. Guafni. Before you had to round in your own service in perpetuity, so the junior resident rounded every weekend. And so you can imagine the difference in your lives because of people that came before you. He is the David Silver Professor and Chair of UPMC, which is a huge department. I think over 100 faculty, so quite large. He's also the Chief of the Foot and Ankle Service. He is Professor in Bioengineering as well, so kind of following in the footsteps of Chair when I started, Dr. Lorenzen. And he's from Alabama, so he's from Muscle Shoals, which is the top left corner of the state, kind of in the middle of nowhere. Somehow he wound up being an Auburn fan, even though he's much closer to Tuscaloosa. Played football in high school, actually played quarterback. We played some flag football times when he was a resident.
I was a fullback. I was an unassuming quarterback, but I was a distance thrower. We'll talk about that. People with down the short man's arm.
It's fitting for the diversity discussion in that he went to Xavier University. Xavier's in New Orleans, so at the time, and probably to date, probably has put more African Americans in pharmacy, dental, and medicine than any other university in the country. I went to Tulane, so we were right across town, and almost everyone there was going into medicine and pharmacy. It's outstanding. He then followed that and went to Howard University. So again, another university that put a lot of people into medicine for his medical school, and then he matriculated here. So he graduated here in 2012. And that class has been quite outstanding. We've had Dr. Taylor here as a speaker. We obviously have Dr. Guafni here, and then now Dr. Hogan as well. He did his fellowship at HSS, and then from there went to UPMC. And so from there, his career skyrocketed. So you can imagine in 2013, you start as a faculty member, and by 2022, you're chair of that same department. So you can see how quickly things can escalate in a positive direction. He excelled as a leader. He was an assistant program director pretty quickly off. I remember he called me and asked me about that. I said, good luck. His research career had skyrocketed, and some of that is rooted in his time here. He worked in the lab with Dr. Chawber. So again, careers are intertwined. Dr. Chawber's career also skyrocketed, and some of that had to do with some of the work that Dr. Hogan had done. There's over 150 manuscripts, presentations, and so you can imagine those as well. I almost messed your thing up. He's the foot and ankle consultant for Pitt University, also Pittsburgh Steelers, Pittsburgh Ballet, Duquesne University, Carnegie Mellon, I think some other places as well. And despite all that, he still finds time to stay connected. He's one of the residents that we have that's the most connected with former alumni. He knows or has stories about just about everybody. He reaches out and communicates probably more than most, which I think is a gift. He also spends quality time with family. So his wife, Danica, is a wonderful individual. He has two daughters who are excelling, potentially a rower and who knows what else. His 8-year-old is as big as his 11-year-old. So you know how that goes. And so the idea that 10 years is pretty unprecedented to go from start to chair. And we have 2 people actually in the room who've done something very similar. And it's interesting that they work together. And so we're excited to have Dr. Hogan here to speak to us and enlighten us on his path, as well as some foot and ankle stuff as well.
And mic drop. So we're done. You get the whole story, man. I appreciate you. As Dr. Dacus mentioned, and Bobby and Winston. Oh, I got to push this button, right? So Winston, what I do find amazing also is that Winston's still the AV person. So, but not completely surprising because it was essentially when we were, is this working? Is it on? I'm good. All right. So when we were residents, and everyone here will remember this. I mean, once you were the AV person, you were always the AV person. So when we were residents, the person in the lab did the AV. So we had, the 6-year track, and Bobby remembers this. And so when Winston and I became admin chiefs together, essentially you're like the PGY 5 and 6, but you were still the one responsible for the AV. You go in a room with Miller, something wouldn't work, and you're like the chief, and you're like, okay, I'm supposed to relax now. He's like, Mac, can you help me out here? And I'm thinking to myself, like, what the hell is the intern or the lab resident doing? But now, again, culture doesn't change, so it's good to see that Winston is still on the AV. Oh, okay, great. So who did? Who did? Chopper did? Yeah, exactly. So again, culture, right? So in fact, the chair still knows how to do that. And earlier, I was trying to get this puncher to work, and I just basically went looking around for the USB to connect it. And I can't remember if it was Frank up here or someone. They were like, I can't believe you still know how to do that. And I was just like, you know what? The things I learned at UVA, because I definitely didn't learn that in Alabama, so I love my home state. So we're gonna have a little fun. I'll give this talk. We'll take a break, and if we have a good time, we'll also go a little bit into the bioengineering of foot and ankle injuries, and some of that intertwined in here as well. Because, my path here and through UVA, from a family perspective and academic perspective, research is a key element of that. It was kind of interesting too. You don't think these moments are going to be somewhat surreal, and this is also what I'll also say about the program. This is not the first time they've invited me back. Beware of the program that the only time they invite you back is when you get a title they care about. I've been here 3 times. Before COVID, I came for a couple of the alumni events, and so as mentioned, the department program has always been kind to me, and I'm thankful for it, and my family is as well. So we'll talk a little bit about that. See if I get this actually. Okay, great. No major disclosures. Even the industry disclosure that I have. I'm an unpaid consultant for BioPro. You're like, why would you be an unpaid consultant? You guys are like, yet again, an idiot academic chair. And I'm on the health equity board for Zimmer Biomet. But one of the things when we talk about conflicts, again, working with industry, you cannot innovate in our field without working with industry. But to that point, I also am in a position to still be the arbiter of 95% of the decisions around orthopedic implants and utilization in my health system. And if I have 35 billion conflicts, don't call Mac Hogan when you want to get your favorite anchor. I'm going to say good luck. The chef's back there smiling. So you have to, again, am I leaving money on the table and my kids may not be able to eat because I don't have 35 consulting agreements? Probably not. I think they're going to be okay. However, everything comes in phase and time. And if the good Lord lets me live long enough, I'll consult after I retire. So Freddie Fu, the reason I put him up, I'm in this position not only because of the individuals in this room, and we'll talk about it, but it is important because I met Fu the first time when he came to UVA when I was in the lab. Mark Miller invited him, some of the people here remember. He was on his double bundle tour. He was already famous. I see Dr. D-Duck and Trey smiling. He was already famous. And he would tell people that. I'm already famous. I just want to be a little bit better. And this guy showed up here. I'll talk a little bit about it later. He drove from Pittsburgh because US Airways just lost their hub. Charlottesville Airport was still a disaster. And he said, I can't fly there because I have to do a connection. And so he got in his car, 2 of his research fellows, and drove down. He pulled up in his A8 sedan, and I was in the lab, right? So the lab track, and I volunteered. Erica and I just have to rotate, giving the tours to the visitors, and I said, okay, I guess I've got Dr. Fu. He pulls up, he says, you drive me for the next 2 days. He said, I was just like, what the hell is going on? He said, you know where you're going. My research fellows have no idea. right? And so essentially for 3 days, I drove him around this AA, brought him here, to Starbucks, we were just floating around the city in this sedan. And he remembered that. But he also, I bring this up, look for things in small places. Not only did he come here to give grand rounds and fight with Miller and D-Duck and everybody about why would you change how we do ACLs when it works. He knew that our anatomy lab at UVA had one of the largest repositories of fetuses with preserved knees. And so he goes and finds this lady, and she opens this door in the anatomy in the med school, and all these preserved fetuses are there. And he goes one by one with a microscope and his research fellows looking at the endocardial notch. That's when I realized nobody can compete with this guy research-wise, right? Already famous, already wealthy, and he literally comes down and say, "Hey to Mark," and he knew what was in our own building, and we didn't even know it was there. I think Chauver knew it was there, and like Miller after Fu told him. And so, hence, and so that's how I met him. And then we'll talk a little bit later. Several years later, my wife moved to Pittsburgh, and my wife's brother moved to Pittsburgh, and then I called him about a job, and the rest is history. So, a little on who I am, a little on what I do, a little on why I do it, who I do it for, a little on why research, and a lot of the people who helped me. So, when I became chair, when I was in this hunt, I called Bobby and Dacus, a lot of these people quite a bit, and just asked advice about things. And over the first, when you stepping in the shoes of a major institution of Dr. Fu's shoes, but you can never fill them, but how do you move things forward? And I really wanted to take this approach of how can you amplify and project something that's already going so well. And so I came up with these R's, and I did it with the Falcons. So we had a couple of Falcon meetings. And for those people who didn't move, he didn't need any Falcon meetings. By the time he was in the latter part of his chairmanship, he knew everything going on by just simple phone calls and text messages to loyal, good people, just being aware. So even when he was flying over Singapore, you knew he knew what was going on back home. But after Falcon, I said, hey, I gave him an anonymous bucket of things and said, just write 3 or 4 things down that are important to you. Just put it in the basket. And I didn't make them pass the basket. I said the basket's at the door. When we leave, just drop it in, right? It's the anonymous, box. And most of these things came out of that. So how do you respect the past, embrace the future? They came from Ferguson and also Fu. I think they were very much traditionalists in our field, but they understood, you don't respect the past to stay the same. You got to move forward. I mean, this building is a reflection of that. Like, how do you continue to move forward despite your opinions and perspectives? Residents and fellows are truly our legacy, right? Now, we've traded stuff. I've been a PD. I've had the roles, APD, program director, chair, fellowship associate director. I currently sit on the torturous aspect of the RRC last year of service. But resident and fellow education is truly our legacy, right? If we don't put you guys in a position to be successful and know where the puck is going, despite the challenges you're going to meet, we have somewhat failed to a degree. This is a hard one because having kids, and I hate to refer to you guys as kids, but you think about it that way, because you're all adults. But also, I remember Richard Grant told me, residency and fellowship is the last time someone actually cares about your education. Last time. After that, you just hope people care. So you got to see that once you go in practice. Not to make it doomsday, but you'll be great. I'm doing okay. Research is an essential aspect of our identity. So Pitt's always been big on research, and relationships matter. Patients, colleagues, alumni, partners, Pitt, UPMC. And then my thoughts were, if we continue to do these things well, our reputation will continue to rise where it should be. And it is up to the chair to identify resources. How do you recalibrate? How do you reset? And you need partners to do that. But the thriving principles, remember, things could always be worse. So my dad taught me this. So no matter how bad it gets, no matter how pissed off I am at a resident or a faculty member or myself, I try to always say to myself, it could be worse. This has also helped me a great deal in the operating room. Keeps your heart rate down and you keep moving. Relationships matter. Now, well, I'll say I have great relationships with everyone. No. I mean, every once in a while I'll hear from someone, they're like, oh, I can't get in touch with you. And I said, maybe because the only time you reach out to me is when you need something. But you know what? I'll give you a call back next week. and you kind of just keep moving forward. But relationships matter. How you treat people matters, right? That's one of the problems with the world now. We're tight roping on a knife blade, thinking that it doesn't matter how you treat people. And most of that is because we do most of our bad treatment in a silo in a box. And I'm not a polarization person, but you'll get a little bit of that in here, right? Find a way to have some level of compromise. Remember, we are in the greatest field in medicine. So orthopedic surgery, you talk to your colleagues, and my wife's a radiologist, so I'm not offending any other specialties if you have friends who are it. We're one of the few groups that's not running from what we do. If you go specialty by specialty, they're spending even the administrative thing, the burden that Bobby and I talked about yesterday of you enjoy doing orthopedic surgery, you enjoy doing clinics pre and post-op pain and discomfort, Tom Brown quote. However, we actually like what we do. So you talk to other specialties, they're doing everything possible to get off the wards. How do I get as few ICU rotations as possible? How do I actually find a way to do fewer transplants because I can't stand up for 10 hours? We actually enjoy orthopedic surgery. So we should take pride in that and run with it. And remember who you're in the game for. And that's what we'll talk about a little bit. So mentors. So this was me, I'm a geriatric millennial. Where did I get this from? One of my partners, when I interviewed for this job, people said, Mac, you're 40, your early 40s, how are you going to deal with people who are 50, 60 years old? So I told them two things. I said, my brother's 10 years older than me. I said, I've always had to work with people who are older than me. And I said, you cannot erase the value of time and experience. You can't mitigate that. You can't just try to wipe it away like, oh, it doesn't matter. Old people need to leave. And then I said, you kind of respect people where they are, meet them where they are. Again, verdict's still out on whether I'm doing okay with that. And then I was talking to one of my faculty members who's 60, and he was complaining left and right about his kids, about the residents. He's like, these freaking millennials, they're a problem. And so I said to him, I said, I said, you realize I'm a millennial. I was born. He was like, really? He's like, when were you born? I said, I know the numbers. I've studied this. I said, I am a millennial. I was born in 1980. And he said, well, Mac, you're more of a geriatric millennial. And I was like, what the F is that? Right. But whatever it was, it allowed him, we have some of the best conversations, and you get the perspective of someone who's had a great career, but how do you address those frustrations and turn it to good? So my first life and business mentor, so I have one brother. Both of these pictures side by side. This is when I thought I was, the hottest thing coming. This is my senior prom, right? And my dad was there. It was back when the button was hot, but no bow tie. Contacts are better. But both of these pictures, my dad still has a power beard that I cannot compete with. Were both the pictures we took the first time we saw each other after COVID, right? So my mother unfortunately passed away last summer, but I have a picture of her later. But this was the first time we saw him. You didn't really know what was going to happen. Were you going to see your parents or not? And we surprised my brother for his 50th birthday, and my daughters were the ones who walked to the door the first time we traveled with them after COVID. So, but they were my first mentors. And so find your goal, know your goal, own your goal. The path will come. We'll talk about that. So corner of the state, and Dacus really did give my whole talk in like a 30-second intro. I grew up in Muscle Shoals. It's a big music town. I was a fullback. Football was life there, right? Food, football, and religion. I had a horrible fracture dislocation my senior year, Weber C fracture dislocation. And it essentially was this story, right? Running the ball, the defensive back who was on my back saw my ankle. The guy cringed and started running to the other sideline. And the trainers ran on the field, and everybody was coming out, and it was carted off, ambulance, the whole thing you see on TV. And this is how it was fixed. This is not my X-ray, right? So who here is doing trauma? As I see Dr. Weiss's eyes honing in on that joint alignment. Who here is doing trauma? Anybody? Who wants to say what you would do with this? How do you feel about this fixation? We'll have a little fun. Anybody?
Yeah, rolling.
What do you think about it? Okay. That's what I mean. It's good. This always wakes people up. Okay, what do you not like about it?
Beef up my syndesmotic fixation as well.
Okay, you beef it up. So this is great. You guys want to know where this was from? This is how it was fixed, single screw. Didn't look like this. This came out of skeletal trauma. Circa 2010, standard of care, appropriate picture, probably from a godfather of trauma surgery at the time. And Weiss is smiling because yes, we should have gotten this at the length, right? Now, this would be Monday morning quarterback. Everybody's just like, this is horrible. But back in the day, clamp it, young guy, screw. He will heal his fibula, which I did. My fibula is a little short. He didn't leave me this short. But this came out of the textbook.
Big screws, you can take that in clinic.
Exactly. Bingo. He knows the deal. Take it out in clinic. And if you're in Canada, you're taking it out in clinic now. Like you actually say, hey, great, come in, little numbing medication, boom. This was standard of care back then. Be careful with that standard of care work, right? So, but this is me now, right? We'll talk, so fibula healed, so my left ankle. Deltoid was not fixed. We still debate that till this day. I had surgery in 1997. We still debate deltoid fixation now. Think about that. We have a tendency to just do things over and over again and actually not solve it, so we actually can stay employed. But I got a little medial joint arthritis, some cystic formation. Never let anybody do an MRI on me. I've got a huge loose body in the front of my ankle. I've had that for probably a couple of decades now. When I was a fellow, I thought about removing it, but O'Malley offered. I said no. You know, Joe Park has heard this story, and so I rarely get problems with it. And each time I do, I just say I need to lose a little more weight, stay mobile, and I haven't had to start injections yet. But everybody's kind of looking at it like, let's see how this goes. But if you see me limping at the academy a year, 10 years from now, you'll know why. So this is the guy who fixed my ankle. Did a good job. Name's A.E. Joyner, and this ties into a great story. So Joyner, North Alabama Bone and Joint Clinic, former Andrews fellow. When Jimmy Andrews came to give Grand Rounds here in 2008, I told him this guy was my surgeon. He was like, he was a great fellow. First surgeon I ever worked with. At that point, I was interested in medicine, but I thought about family practice or peace. That's all I knew. He was on the opposing team sideline, right? So how do you actually cross, how do you cross to the other side and contribute? I shadowed him every summer, every holiday. Still talk to him. Wrote my letter of rec for med school and for residency. And his son is also, is now a chief resident down at one of the DO programs in Georgia, is going back to practice with him. His son came to work with me for 3 weeks on my research team when he had an elective when he was a fellow, when he was a resident. So full circle. That guy actually knew my dad and my dad's family, even though we were opposing rivals from years prior. So when he came on the field to reduce my ankle, he saw my dad. And he said to him, my dad used to be a coach before he went into business while he was working through grad school. And he said, Coach Hogan, is this your son? He was my dad. My dad was one of the 7th grade basketball coaches, right? Which I was like, my ankle hurts like hell. I don't know what's going on above me, and so again, he was vested. And so I took advantage of that opportunity. Then I went to Xavier, as mentioned. So I can't speak to this, as we talk about diversity. I went to 2 historically Black colleges, Xavier, Howard, and then UVA and special surgery Cornell. So I've had the spectrum of America, right? So Norman Francis still, I think, has the longest standing presidential reign. He's retired now. He was the president of the university for 47 years. I have no idea. I don't think any president will survive 47 years in the current environment. For me, yeah, I mean, it's like years ago that was aspirational, right? Oh, do you want to be, remember we talked about that? Do you want to be university president? What do you want to do? Now, it's like, absolutely not. Like, you couldn't give me enough private jet flights to want to be a university president right now. But Carmichael helped build the empire, and this was my biochemistry advisor. She was, we feared her. She would give these quizzes and stuff that basically pop quizzes, things that you just tortured undergrads with. And she would always do it the weekend after big parties. But she's now a university president at St. Mary's College, about to retire. But she would say this. She would just say, I'm going to take you to the edge of what you think you can do and show you the door beyond your limitations. And so she happened to be the first African-American woman to get her PhD from Purdue in biochemistry. So, she was mini brilliant. And Carmichael would say, no one said it would be easy, they just said it could be done. But it was a family place. So if people said they did not want to go into medicine or health sciences, or they tried to change their major, he would call their parents. Think about that now. You try to call someone's parents, it's like class action lawsuit. He would call their parents, and people would come into his office and say, you called my mother and told her I was changing my major. And he said, you were bullshitting. So yeah, I called your mother. And he'd be like, get out of my office. And people would come back years after year after they had finished med school, Richard knows, after they finished med school, they would be in practice and they would come for alumni weekends and they'd be like, I'm glad you called my parents, right? And they're doing okay. Now, it doesn't mean everybody has to be a doctor or go into health sciences, but he cared about every single person. So Xavier was great. As mentioned, I pledged, so I had fun. Some of you guys know this guy. So of the 8 of us who were pledging here, 6 are doctors. This is David Ford. She's actually one of the orthopedic trauma docs at Mount Sinai. He's a superintendent, and this guy's like a nuclear physicist, photonics guy. Jason's just weird and smart. But that was who I hung out with in undergrad. So, but research. I did research in an NIH program 10 hours a week for my junior and senior year. So I was odd like that, but they paid, right? I needed money to do things, so I had a stipend. This also speaks to the diversity conversation, right? Anybody want to guess what this was called years ago? It says maximizing access to research careers. This is an NIH program. You want to know what it was called in 1999? Minority access to research careers. You know when this changed? It was before the social justice movement. It changed because of institutions in California more than a decade, 15 years ago. For them to continue to be able to get funding, name changed. You look at the picture looks like this room. People from everywhere, right? So, I like to tell people, we always assume that by changing the one little thing that irritates us, we're going to change the world. Okay, you get to decide. But if you go back far enough, this changed when California had the first affirmative action rule. Funding didn't stop because California didn't want to what? Lose the cash. They said, hey, we will find a way to keep the NIH money flowing through here for research. So, but that's what the program's called now. Still called MARC. No one knows the difference. Now you guys know. So go tell someone in the chat box. I'm sure they'll research it more for you. So research at the core development. So because of MARC, you had to do research in the summer in undergrad. There was no choice. There was no thing you could opt out of, right? So my residents try to opt out of so many things now, it's unreal. But we have a great program. So I spent whole summer at Purdue, whole summer at Harvard. Keelan Miller, who I'll talk about, I matched here with. Keelan Miller and I went to 2 different undergrads. We spent the entire summer at Harvard together because we both were in the research program. He was in one in the School of Medicine. I was one in the School of Public Health. I worked in Lori Glipsher's lab. She's now the president of the Cancer Center in Boston. That shall not be named. They're in a little bit of trouble. But she was great. And Dr. Sung-Young Pai now runs one of the NIH institutes. And I still email with them. When you mentioned staying in contact with people, I still email them regularly. And, they say they're surprised I stayed so close to academics and research. They were like, most people go to med school and then we never hear from them again. But I enjoyed academia. So I went to Howard. So you want to be an orthopedic surgeon. So Richard Grant, who's a good friend and colleague of a number of people here, particularly Dr. Hurwitz and others. He had just stepped down as chair when I started at Howard as a med student. He said, you want to be an orthopedic surgeon? And I said, yes. And he said, okay. He said, I'll help you. And we do whatever I can do to help you. His partner above him, who's in a different group, was Tony Rankin. So when I was at UVA, Richard Grant was the president of the American Board of Orthopedic Surgeons. And Tony Rankin, who was in the presidential line of the academy, was in the floor upstairs. So, and these guys were busy. I mean, they were seeing 50, 60 patients on a slow day. Other days, you were like, I can't believe you remember these people. I see Dr. Hurwitz back there smiling, but that's where I started. And then Howard was great. So, Terry Thompson was the chair, Bob Wilson, who knew Bobby here, and also Dr. Deduck. They used to play basketball together at Harvard, I remember. They talked about it in old school Vandy Hall. So relationships matter. So I remember when I interviewed here, Bob said, oh, did you beat my old med school classmate, med school colleague, Dave Deduck? I was like, okay, he was in interviews. And so Rankin, I had a great time. Bonnie Mason, a number of you know her. She started Inf Dimensions. That didn't exist when I was a resident. But she probably single-handedly is, between her work, the Gladden and Ruth Jackson, probably single-handedly changed the demographic of our field for years to come. Alvin Crawford, you're wondering where this came from. So Crawford, he was almost like Fu, right? He helped establish Cincinnati bracing, the Ponseti method, and it's how people touch you in your career. He had just stepped down as chief at Cincinnati Children's. And so that he would not be a chief who was essentially meddling in the new chief's presence with Peter Stern. Peter Stern was there, and they had an agreement that he would go on sabbatical for a year. I don't even know if we can do that anymore. It's written in the university bylaws, but I think if I try to take a sabbatical or give it to someone, there's no way they're going to let you go free for at least a year. So he did sabbatical for a year. And instead of just taking vacation, he taught anatomy at multiple med schools around the country. He went to several sites he always wanted to visit. So Howard was on the list. And yet again, I'm the tour guide. So he shows up for a month. Thompson and Wilson call me because they say, hey, you're like the med student. You're the co-president of the Interest Society. You're going to basically give this guy the tour of the med school and track him for a month. So I would take him back and forth to Grand Rounds, anatomy lectures to the med school, all that good stuff. So, and that's where I met my wife. So she's definitely my better half. She tolerates me. She's a women's imager and cancer imaging specialist. But few are lucky to have the opportunity to find the better half. So this group knows. We lived apart for 6 years. We didn't live together until we moved to Pittsburgh. She did her internship in DC and then her residency in radiology at Drexel in Philly. And so we put in, at one point, I wanted to buy stock in Amtrak. Like, you know, a lot of the faculty here remember this. So I just kind of roll in, roll out, but I never, we just kind of worked things out. So Winston and I had a vested interest in this weekend rounding concept that we actually implemented because both of our wives were physicians, you know, we're residents as well. I think both of them were like, I guess we have to have kids eventually. Like, so we got work here to do. Like, so you can't be working all the time and rounding. But so that's great. So the road through UVA, and this is where it gets fun. And then, yeah, we're good on time. So I've got a little cascade of things that I'm going to talk about. And for lack of a chance of missing every faculty, I've got something at the end on everyone. So when I started here, and this is what I tell people, you think about some things, right? When I came, we had the 6-year track. It's great. I had three chairmen, you might as well say, right? You say that anything now, people would be like, this is the most unstable environment on the planet. I had 2.5 chairs when Bobby was coming in as I was leaving. I had 5 residency directors over the course of that time. It was a different set of residency directors from when I interviewed than when I showed up. Last I checked, I turned out okay. You know, we turned out okay. And looking at this building, the program's doing just fine too. You know, and we'll talk about these double screen computer suites you guys have. We'll discuss with your name on it. We'll discuss that a little bit later. I mean, you know, off the record, so I don't get the faculty, so you guys don't try to write them up. You know, but so when I came, Kata was the chair, Dr. Hurwitz was the program director, and Dr. Chaba was the associate program director at that time. And then Dr. Hurwitz, you know, as he knows, I remember the day he sat us in the room and said, I'm moving on to become the executive director of the board, and I have to move to North Carolina. And at that time, no one had gone into foot and ankle in our program. I can't remember. I was told 25 years or ever. And so that was a little disheartening because I was interested in foot and ankle and he was leaving, but we stayed in touch, stayed connected, and he and Lorenzen are part of my bow tie journey. The next year, so at that time, you know, Chopra took over, we were in good hands. Carson was one of the APDs then. And then what happened next was when I was in the lab, that's when we met Dr. Dacus at the San Diego Academy, when he was still a hand fellow and trying to decide if he was just gonna stay in California or come back to UVA. And then with Dr. Miller, he was the first case I scrubbed as an intern. So I show up as an intern and the chief resident, Trevor Starnes, he was the senior. Trevor was like, you're a lab track guy. I was like, yeah. He was like, we usually help each other out with cross coverage. You know, and I was like, oh, okay. You know, I'm green. I'm like, I'm the intern. What do you need me to do, sir? Yeah, I need you to cover Mark Miller while I go on vacation in 2 weeks. I was just like, no problem. Scott Wing was the chief. I show up, I saw Miller last week, but I show up to, and this is why somebody asked me last night, how did you get out of here without being a sports surgeon? We'll talk about that. But so my first case I ever scrubbed in the department is with Miller trying to run his second room at the surgery center. And this is still when he had the cold suits and it would break and he couldn't cool himself down enough. He's sweating, he's angry. And he literally goes bananas. He's like, where'd you go to med school? You have no idea what your anatomy is. Where are you oriented? So, and I just kind of stood there and just kind of took it. So the next day I go to the cafeteria to lunch. It's a lot of side stories, but the residents are whispering about it. It was so bad. We feel so bad for him. And I was like, oh yeah, what are you guys talking about? And Wayne is just like, you got annihilated yesterday. He's like, and I was like, I don't know if it's a problem that I didn't notice I got sodomized or because I didn't think it was that bad. I was just like, you know, I was like, look, what did he expect of me? I'm like an intern, I've never been there. And Trevor was like, you'll be fine. But then I came back the next day and I remember Miller, I was in clinic and he said, all right, Hogan, we're gonna try to learn some things today. And that's what I was like, hey, you read day to day. And by the end of that week, I knew how to identify a rotator cuff on a shoulder MRI, right? So, but again, I didn't think it was that bad. Yeah, and I still don't. And Miller has been, and then he asked me to help with the Miller review for a number of years. So again, I think Carson was one of the PDs as well. So we'll talk about that. So this was my match class. So you came in, and this has helped me because at Pitt, we are the last program, one of the last programs that has an extensive research track, and we match half the residency into a research program. So 8 residents, 4 going to the lab. So from the time you come in, you know you're going to get umbilical cord cut from whoever you came in with. It's guaranteed. And it's a match. It's not attritional. We don't say, oh, you go in. It's not old school general surgery. So when we came, Erica Taylor and I, as mentioned, Taylor Webb, she was Erica Taylor then, but now Taylor Webb. We were the lab track residents. She was in Lorenzen's lab. I was with Bobby. We both work with Bellion. Keelan Miller, he's now in practice of resurgence. Yao Bawachi's at Duke. Melissa is in Iowa. She was here, I think, for Tom Brown's retirement. And this was my graduating class. I had a better picture, but then I saw this on Mindy's desk. I couldn't believe it. I was just, it's so, and this is the group we graduated with. This was Richard Grant when he gave our graduation speech, but John Scanelli did joints. Erica Taylor Webb, who you met. Laura Gill is doing P's, me with the bow tie now, and then Winston. And so this is when we graduated on the lawn. So I'll tell you the bow tie story very quickly. So Dr. Hurwitz, when he was here, he said, I had all these interests and that have gotten me in trouble. He said, so you want to be an orthopedic surgeon, foot and ankle surgeon, scientist, and educator? And I said, yes. And he said, okay, right? So your mentors, he didn't tell me that's a lot of work to do and it's kind of busy. He said, let's focus some things, which I still haven't gotten better at. But he encouraged me and he said, get a walk on water recommendation. Don't piss anybody off. Don't piss the wrong people off and you'll be fine. I also covered foot and ankle vacations for the senior residents more than I think anyone in history, because I was the only person in the department who was interested in foot and ankle. So every time someone was on that rotation, it was a single resident, the PGY4, Shep remembers this, then Casado, and anytime someone went on vacation, they were like, Mac will cover it, because everyone else was running from what they assumed was foot pus. Listen to your mentor. So when I was in the lab, and Bobby, and this is going to tie to our research, Lorenzen, he was in and out. He was a great mentor. And so I go to him with a grant, the OREF grant. He wanted to review them all before we submitted them. And he said, I reviewed your OREF grant application. And I was like, yes, sir. And he said, more pictures. He was literally like, you just need more pictures. And I was like, this guy didn't read this thing. I was pissed. I was like, there's no way he read it, but I didn't say anything, right? I didn't send him an email saying, Dr. Rinson, I really feel you should give me more time and that you were not focused while you were in my office. I didn't say that. I just said, yes, sir. So we get this regenerative grant. This was the work that Bobby and I did over years. And he was right. And what he said to me, he said, look, people are basically repurposing their R01 and DOD grant applications for this OREF grant. Like, don't let anybody fool you. They are using higher level grants. He said, you need more pictures, you need more science. And so we revamped the pictures, like the writing he was fine with. And we got this grant. And so you see here that I'm in a regular tie. So when this is an old picture, and Dr. Hurwitz and Dr. Lorenzen saw me at the AOA meeting, like literally as I'm going into practice. And they said, oh, are you doing, you got this two-way thing going on. You're going both ways. Like, you're into bow ties or you into regular ties? I was like, well, I've got a lot of regular ties. I don't know about the bow tie thing. I'm trying to figure it out. And they literally both were like, you got to pick one. You cannot go back. You can't go back and forth. You can't. And so my break point was, okay, I will start bow ties when I started Pitt. That's literally how I went exclusively bow tie, because they both were like, you can't go both ways. So, and I said, you got to pick one, right? Dr. Hurwitz remembers that you got to pick one, Mac. And so, a lot of our work in tendon regeneration and cell science, and again, more pictures, and the pictures work. So our research team was great. Gary Bellion, I know, is retired, and our UVA Ortho labs. It was just a great time. Roshan James is now in private industry. He was like a monster postdoc. Josh Lee remembers Roshan. And so for several years, I operated on probably 1,000 rats, and we passed this, program down year to year to the lab resident. And we wrote this article on what the future may hold as it relates to bioengineering, regenerative therapies, scaffolds, growth factor cells. We've done a couple of updates to this. And it was basically off this Grat tendon model, right? So this is where you go kind of like path, right? And we almost got shut down by the animal people once. Dr. Chow remembers that. We had to do meetings with like the vet. They're like, your splints are like harming the rats. Like, you can't do that. It was a whole thing. And then it was basically a way for them to make money. We had to use their facility after they, quote unquote, caught us torturing the rats. So just remember, follow the money. But this was our tendon gap model. And I remember the reason I put it up, just to bring back deja vu for Bobby. We would make this defect, we would bridge it with this polymer that had GDF5. And when you look at all these scaffolds that are out there now, what can hold growth factors, what can hold what type of cells? And we had adipose stem cells. And this was the power splint. You remember? Oh yeah, we would be in there putting it. He came and Chopper would come over. So I learned from the best. When he had a break, he would come over like, I want to see what you guys are doing over. He would come over and operate with us. We did
projects over.
My job was to look at
Yeah.
how they were operating.
Yeah, and this is what they approved. At first, we had this evidence-based thing, and they said you can do this. So this is basically Coban with a strip of plaster and a posterior splint, and you had to put it on the wrap before they woke up. I knew you'd get a kick out of that, right? So so that they could move freely around the cage together, and you had to put anti-chew spray on each splint so that the rats wouldn't chew through their buddy splint to get it off. Think about how hard we make research, right? My UVA journey, right? So we did that, but it worked out. And I remember, look, this for everyone here who wants to do basic science or even translational research, it's a labor of love. I mean, you have to be committed. And each year, we would publish a paper, and it would be one by one. We would get these rejections, and then these journals. Every scientist. We had one revision where a senior scientist said, "How are you going to get fat cells from an elite athlete where their body is only 3% fat?" Remember that? And then we said to ourselves, we sent in the revision, it got approved immediately. But don't let the simple stuff discourage you, right? And this was frustrating because clinical research, I do, and I'm not in any way knocking it. It has to be translational. But if you're going to do basic science translational research, you just have to know you're going to get tortured, and you're going to have things that get denied and rejected. Don't just run to open access just because they want your money. Like fight the journey. And this worked out for us. And as Dr. Dacus mentioned, I think Dr. Traver had one of the fastest ascents from assistant professor to full professor probably in UVA's history. And so this was our electrospin. And then I was fortunate. So this will tie into Pitt, and then we'll go to some closing fun. So going into my first year in practice, our research won the top foot and ankle science award, the Goldner Award. Our labs now, and that was great. This was, Gold, John Gould, who was head of foot and ankle at UAB. He was also a Pitt alum, which I didn't know at the time because I didn't know my history well. And so I had signed at Pitt. He said, "Yeah, Freddie sent an email to all of us, said you're coming." And so at the award ceremony, my fellowship year, we took a picture together, and this was on the cover of the PLJ. So I went to HSS. They've diversified a little bit since then. But these are the people I work with. Bill Hamilton, as Dr. Hurwitz knows, he was one of the godfathers of sports foot and ankle. He passed away about 3 years ago. He was still working when I was there up into his 80s when we talk about who's going to stop operating. He was probably like mid-70s, late 70s. Martin O'Malley, who's basically one of the star foot and ankle sports people in the country now. I did a lot of health equity work at that time with Michael Parks, and because I did so much sports medicine coverage here, the HSS residents knew it, and they were the same thing. They needed help with coverage, and they were like, "Who's willing to cover a game?" I was like, "I'll do it," because my wife was in Philly. She didn't want me to be around because she was studying for boards. And so Riley and these guys were like, "We'll pay you." It was like penance, but you just got access. So I was there when Barclays opened. So I basically covered the first Atlantic 10 tournament with Chris Jones, who's now the team doc for the Lakers. And I would cover sports stuff on the weekend just to help make extra cash. And so I got a lot of exposure to sports foot and ankle while I was there. And just a great lineup of people who taught me there. So, but why did I go to HSS? Reputation, surgical exposure, clinical outcomes research. I understood basic science from here. I had a great training, but I wanted to understand clinical outcomes, patient-reported outcomes, where the world was going. And that was one of the reasons I went there, and it paid off. As Dr. Werner and Brockmeyer can tell you, this place was a factory in regards to that. And so the unexpected happened. So in 2012, going back to the guy who my dad coached, ORAF called me and said, "We want to do an expose on your story with A.E. Joyner." And I was like, "Why?" But I said, "Fine." His family, this guy's a private practice guy in North Alabama. His family was one of the largest family donors consistently to ORAF for decades. They used to own a bus company. It used to be called Joyner Bus Company. I remember this. Greyhound was basically built off buying off all of the small bus companies that existed around the country. So they were not a bus company when he was still, obviously he's an orthopedic surgeon, so he did okay. But they had this bus company, and so he would donate money to research. He did a 6-year research track at Orlando, always had an interest in research. And so full circle, they said, "We want to tell this story about you guys meeting because we heard about it." And here he says it. I said, "Hey, he realized I had an injury. Didn't know I was going to be featured in orthopedics." And Dr. Joyner from the opposing team sideline, came on the field, fixed my fracture 4 days later. He also casted me in the ED, no bivalve, right? And if I got compartment syndrome, I'm still standing up. So that was the story. And so again, you never know who you're going to touch. And the reason I mention this is never underestimate the impact you can have on someone, right? And in your community. So if I sat here today and told you, I've had a number of great mentors, but if I told you my start in orthopedic surgery started with breaking my ankle when I was in high school, you're like, all right, sounds like a standard orthopedic story, right? Injury, got into it. If I told you the full circle of how that is tied to my academic career and forward, you'd be like, no way, right? Netflix may want that content, or maybe not. But so my journey to UPMC, it started here with Freddie, took him to Starbucks, as I say, drove him around for 3 days. He tolerated me. Really, I went there, it was always an option to come back here, so I was appreciative of that too. But I went there because we have family there, and then the research. And it has been my journey. So I started as assistant professor. So you just said yes back when I was a resident, and you just said yes when I was a faculty. So Fu called me 2 days before I was supposed to start and said, hey, Hogan, how you doing? It was Labor Day weekend. I was like, Dr. Fu, I'm excited. I'm here with my family in Alabama. He's like, great. People who knew Freddie, very quick. Good. You're going to be associate program director, okay? You go talk to Deanie, our senior program director. You see him on Wednesday. I announce you at opening grand rounds. You'll be great. And he said, I already talked, and I was just like, with Dr. Fu, he said, I already talked to your people. He had already talked, you'll be fine. He cuts me off. It's like, you'll be fine. Hangs up. Like I was just like, yes, sir. Click. And so my wife was like, oh, what's Dr. Fu talking about? I said, he wants me to be the associate program director. My wife was a resident. She's like, how the hell is that going to work? She's like, you just graduated. So, and I said, I have no idea. That's how I became the associate program director. So I called Chopper, I called it. They were like, what? They're like, all right. So by 2017, the PD was supposed to go 5 years. He went 4. He retired. I became the full PD, associate professor in 18. Most of the people in this room have written my letters for promotion. Decided to get my executive MBA in 2018, which worked out, and then a full professor in 2021. Unfortunately, that's when Freddie got sick. And then after the search, became chair. And so clinical orthopedic surgery is still fun. I love what I do. I still have a research practice, which obviously is extended with the team now. But basic science, translational, performance assessment, and then healthcare delivery research. So fortunate, just like the walls here, there's been very few chairs over a very long department. This is our 125th year. I'm having fun. We have a diverse department. That's a legacy that was started years before me, decades. So Fu used to talk about this. Ferguson in the 70s, when Fu was a resident, Fu would always say, we had a black guy, I was from China, and we had a woman in the 70s at Pitt, right? And Dr. Sharma, who trained there, knows it was a legacy that Fu and Ferguson, these guys, and he would always tell people, we just get good people from everywhere, but you do have to have some level of intentionality. Like, don't believe this thing when people say they're colorblind. I'm not saying you can't say that word, but if you're colorblind, it means you don't see me, right? And if you're actually colorblind, this whole thing about blind spots, bullshit. Blind spot means you look in your mirror, you don't see the car because it's in a technical blind spot. It's not a blind spot when people insult people, regardless of your race, gender, or sexual orientation. You actually look at the person, choose to insult them or ignore them. That's not a blind spot. That's actually an intentional slight. But we use words to make us comfortable. So, but this is our program. Again, I tell people though, don't get caught up in the composite. Because if any of you saw Crash, Academy Oscar-winning film, I tell people all the time, our program is LA on steroids, right? You think that everything's good because you have people from everywhere. It's great. We learn from each other, but again, it doesn't mean that it's utopia. So great sports city. Fortunately, my training here really helped with that and had a chance to take care of a lot of great teams. UPMC is heavy. And as Bobby mentioned, massive 40+ hospitals. We bought another hospital system last week that we finally merged with. So now we're at 45 hospitals. I have no idea how that's going to end. But at the same time, it's a huge health system. It's a lot. We have this complex environment. So I report to my CEO of the hospitals through an EVP like here, and I report directly to the dean. And so each of those are one step from the chancellor here. We have a new chancellor, new CEO, all within the last 5 years on both sides. So that's a lot of change. We have community employed docs. I have about 65 surgeons under me, 20 research faculty under the university department. Under our CMI community division, there are another 70 orthopedic surgeons. If you add our regional partners across the whole system, it's another 150. And we still, private practice docs operate in all of our hospitals. So I get dashboards on everyone. So the immediate direct reports are here, and we have regional directors. And Freddie and I were part of setting up our service line governance years ago. But these are all the hospitals we now have Allegheny County and Harrisburg. One time, and Bobby appreciates this. So this is our mothership program. This is the Pitt that you know, right? That everybody talks about. We now, we acquired Harrisburg, Pinnacle. So we have a DO program here with 25 residents. We have a program at UPMC Hammond with 15 residents. So there are 85 orthopedic residency trainees at Pitt UPMC at any one point in time. And when I was the program director, UPMC was trying to consolidate, and the head of the system called me and said, Mac and Freddie, what do you think are the chances you could run all three programs? and Freddie and I were like, can't do that. Like the RC won't let you do that. Like, yeah, we'll deal with that. But could you do it? And we were like, no, like, it's not possible. Like, that's not how this works. But all of these residents rotate through us with either trauma or children's. And I tell people in the faculty and the community faculty, there's no other program in the country that's training 85 residents a year. Residents. So we have a responsibility because we are going to impact, if anything, the state, the Commonwealth. And it's a lot. So that's a lot of resident surveys and a lot of complaining, but also a lot of opportunity. So, but I like saying this is the academic clinical orthopedic enterprise. And so we have this massive quality center. We have a health plan with 4 million members. We have an innovation arm similar to UVA. We own our own physical therapy. We have worldwide healthcare. We have our first international hospital was transplant. We now have 5 hospitals in Ireland, 2 in Rome and in Italy, 1 in Croatia that they're about to buy. My first secret trip as chair was basically flying into Ireland in the thief of night to help sign off on a deal because we had just bought the sports surgery clinic in Dublin. And they said, we need to take an orthopedic surgeon with us. I had visited it, but I didn't know we were going to buy it before. And so we jumped on the corporate jet, flew back within 24 hours. So if you think private jets are fun, they're not, right? If you got to do a 24-hour turnaround trip, that's not enjoyable. It is an experience. And so now, I mean, we're heavy, right? I mean, we are essentially like tankers, and that's a gift and curse to that. There are certain things that come with that. So most of my faculty understand that when things are going on, you got to build a team for this type of stuff, find different people who are interested in helping. It's not just one person, but research is what drew me to Pitt. So the bioengineering, robotics, kinematics, all of that. So one quick thing on some of this. So Johnny Hewer was a big research scientist. He did muscle stem cells. I started working with him. We then started publishing more and more on the future of regenerative medicine with Johnny and Freddie. I was there when Rocky Twine was there. A number of people know him. And so this guy, Hang Lin, is now, I mean, both Pete and Hang are there. Rocky's moved on. And they're doing great research for us in cartilage. And so we have a number of things looking at bioengineering of cartilage. We'll talk a little bit about that. James Wong was a big tendon researcher. This guy had the first NIH grant on PRP with Freddie, and now has multiple DOD grants, and we do a lot of our tendinopathy research together. Recently, this won the Golden Award again in 2020. Joe's seen this using metformin for Achilles tendon injuries, and we now have a DOD clinical trial. In this group, our research group just won the top research award while we were in Korea, where Joe and I were there. So I'm really excited and just proud of the work these guys are doing. But this is the reality, right? So 28-year-old male, syndesmotic injury, disability. So I still do disability consultations for the NFL. So this guy was like the 4th on his list. He had to see people just to make sure he gets his pension. And they missed his syndesmotic injury. They fixed his fibula, thought it was only a Weber B. By the time he came back, he had full thickness cartilage loss anteriorly. They tried to salvage it by going back and scoping him and then placing a tight rope and a screw because he was 300 pounds, but the guy never played again, right? He was a Weber B ankle fracture. So I'm aggressive with the syndesmosis. I'm like, I would rather put in a tight rope or a suspensory or a screw and over-treat them than they come back and they've already had cartilage loss. So, but the fixation debate goes on, and we'll talk about that in the second talk if we have time. So, these are all the different screw fixation techniques I've used over the years as we jump around a little bit. And it starts with that first one I showed you. And then, I mean, look at this, right? We're still trying to figure out, is it hybrid? Should we do 2 of these? Should we fix the deltoid? Should we not? An orthopedic surgeon, we will debate a sardine out of the can and back into the ocean. I mean, but that's what we do. Our robotics lab, Vocal you saw in Debsky. So we started working with them first. We then transitioned. We created a full-length model. We brought it. The only other place that had done this was in Japan. And so with our robot, we created a full syndesmotic model. Got an ORIF grant to study the syndesmosis. And then started just publishing on fixation techniques, what's appropriate. What we find is with screws, I mean, if you really think about it, screws actually break in people who are active. So especially fixation is just as good, but it does cost a little more. Our biodynamics lab, this entire kind of journey here, I just kind of approached this guy and said, hey, do you want to do some foot and ankle research? And he didn't realize that the foot and ankle needed to be researched because he had just been doing shoulders and knees. And Amherst has, more research money right now than baby NIH Jesus in my mind. And so we've done great work together for over the years, just continuing to try to just drive what we do. And so now we have the ability to track everything. And a lot of this started here. I mean, Joe Park remembers when we did one of the first studies with the NFL injury group with the crash lab here and some of the great work that Joe's team is doing. So, but again, we had a more extensive research talk, but I put this here because we took these patients and it goes back to my journey. No matter what we do with the syndesmosis, you never restore the normal side. We compared it to, we've taken every fixation approach and you actually compare them in normal, healthy individuals and the other side's normal, you never restore it. So still more questions than answers. A little bit on outcomes. So Judy Baumhauer, I met her and I had this interest in outcomes from HSS. She came down and from Rochester and showed us how to build out this model. We essentially integrate our patient report outcomes into Epic. Dr. Harris was on this paper where we talked about performance platforms. And this is where orthopedic surgery is going. If you think people are just going to say, you know what you're doing just because you have great training, guess again. They're going to want to know, what are your outcomes and how you perform. So we did an evidence-based build out and then that has turned out well. I remember Colin Hurwitz saying, hey, what do you think about all these, value-based care, these measures? And he said, Mac, we cannot be the specialty where our answer is always no. He said, it's not sustainable. Somebody comes to ask you a question, you're like, don't F with me, leave me alone. And we say, go away. They just go find someone else. So we wrote this about resident fellow education and where should they learn how to operate. And this was a interesting group then. And that's how I met this lady. So Tammy Menier is our chief quality officer. And we started going down this path together. On efforts. And she asked me to work on a lot of our joints bundle work. And I'm not a joint surgeon. But the reason she did is because she said, well, you're relatively mature. I'd only been in practice 2 years. And she needed someone that the joint surgeons didn't think were still in their patients. Right. So I was perfect. They were like, Mac's not trying to steal my hip and knee replacements. And that worked out well for us. So the bundle started. This is what kind of pulled me into, you can't run from healthcare. There is no escape. And a positive attitude takes you a long way, right? So it gives you power over circumstance. So we built this quality metric marker, and then we'll take a break and then we'll start back up. And that involved, complication rates, and our health plan did the same thing. And so I like this stuff, like episodes of care, costs, quality, complication rates, because I would rather know what's going on with me than someone just tell me when they're trying to terminate me. So I want to know what's going on. I'm the person who's trying to figure out what's going on with the analytics on my iPhone. Like who's tracking me, what do they want to know, and why are they there? So if you look at my iPhone analytics, I go to Fox News and CNN the same amount of times each day together. And I get all the good stuff. I get all the extremes because I go to both websites. It's very interesting. Try it. You'd be surprised what you get. That lets you know they're tracking you, right? When you're getting stuff from every side, you're like, oh, this guy's an anomaly. Right. So, but you want to know if you're an anomaly, particularly if it's going to affect you being able to feed your kids. So we developed this patient report outcomes portal and this whole care continuum. So, and that's helped us. And so now these same dashboards that so all of these were built by our surgeons, right? Surgeon built, physician built with our quality team. And so our docs know how to track themselves and others. And so that's been my experience as a surgeon. And so everybody talks about these report cards and no one cared about clinical outcomes. They care about anesthesia metrics. We built it out and extended it. And so now all of this is basically built based on what the surgeons want to see. And it works, but there's still challenges. And so this is like our outcomes. This is our performance report for everything we do. You guys have similar, but every one of my joint surgeons, our spine surgeons can do it now if they want to, or their practice can basically go in, identify their demographics, and they can actually track their outcomes after. And then pros, right? So we can track where people sit. We don't weaponize it. How are they performing compared to their hospital versus our centers of excellence? And this is the type of stuff you want to build. You don't want to have it be dictated to you. This has helped us generate funds for the department. We now are able to, leverage information to everybody. And it's accessible to everyone, facilities, surgeons, champions, employed and private, and we don't weaponize the data. So, and the impact, $20 million of savings. We didn't get all that money. Somebody's always counting the money, but we invested. That's what launched our Joints Fellowship, our academic training program, our research, our academic productivity, and our research profile. And then the reinvestment, navigators, joint replacement, our fellows. This basically launched our robotics program. So every time one of these joint guys comes to me and says, I want a new robot, I tell them, how are you going to pay for it? And then they say, well, it's good for the system. And I say, well, if you owned your own surgery center, would you pay for it with your own money? And they're like, I think I'll figure out how to do it manual, right? The whole mood changes, right? But when you give them a pathway to figure out how to, actually cover the revenue, look, again, academic clinical orthopedic enterprise, there's no free lunch. So you got to think about that. So we have a COE that's built out for our health plan. This is probably largely part of why the place decided to hire me as chair. And it's been good for UPMC and all the things we published with it in the academy and just profile. So I'm going to take a break there. This is the Platinum Care program we built. And then I have the second phase of a talk, answer some questions. And then I have a couple of some more research stuff, but I also have a couple of interesting memory lane stories for anybody who wants to stick around for that, for everyone. So I'll pause now for questions because that was a little, I can't talk that much longer without taking a break. So questions, yeah, thank you.
Tell us about your time a little bit. What is your average week?
Unstable, no. Look, you guys are probably thinking this guy definitely learned from people like Chabra and Miller, who's like, just rat. So when I first started off, I was 60-40. So I would do 60%. That is transitioning to clinical practice, right? So 60% clinical, 40% administrative. And now it's shifted. So now I'm closer to 50-50. So it flexes up and down based on the week. So my Mondays and Wednesdays are guaranteed administrative days. The only time I would see any patient during that time, if it's literally a VIP who wants, someone's daughter or husband who just finds a way on my schedule, and I do like spot checks, or elite athletes, I'll do that. So that's purely administrative. Then my Tuesday, Fridays flex. So either I'm in clinic or I'm in the OR. I love Friday afternoon clinic. People really need help. Everybody wants to go home. Right? It's one of the only days of the week when people are just not BSing, right? So if it's a Friday, the best clinic is Friday afternoon, but I haven't gotten that bold yet to do an afternoon only block. And so that I'll flex that and then I operate on Thursday. So each Thursday I'll run 2 rooms, alternating. I don't run them simultaneously with the fellow, and it works pretty well. So that flex Tuesday, Friday becomes that other percentage day. In theory, that's very clinical for a chair, but as an orthopedic surgeon, and you talk to my faculty, they're gonna be like, Mac's always moving. Like Scheimer trained at Pitt is one of these places too. They built the empire off surgical volume and just throughput. Like if you just see the amount of work we're able to get done. The other thing you have to fight as you move up, you have to fight, you are your own worst enemy. And that's why I say to myself in the mirror, like on a given day, I'm my own worst enemy. And as you get into leadership roles, the environment actually makes things easier for you, right? So, I mean, if Trauber calls to add a case, nobody's gonna tell them no. So before you know it, you can find yourself being like, oh yeah, just add it on that day. Then you get creep. And so last year when I first started as chair, my VP said to me, she said, you realize you're on pace to do more RVUs than you did the year before. And I was like, well, no, I didn't really realize it because it didn't hurt as much as the year before because all these things, nobody fights me about adding on cases, right? So the environment becomes easier for you to actually become consumed by it. So that's what the schedule is now. I'm hoping by next year, I will be the full swing, 40%, 2 clinical days and 3 administrative days solely. That's the goal. That will still be probably 80% more clinical work than any of the other chairs in our system, period. But I've got a benefit, right? I mean, early on in my career, foot and ankle, everything's outpatient. I mean, I did a below the knee amputation 6 weeks ago and I sent the lady home. Regional nerve block. She was determined to go home. She was relatively healthy, well controlled, but she just had a bad Charcot from an ankle fusion. Sent her home. So I don't have to round. So what the joint guys and spine guys are normally doing rounding in the hospital, I'm doing administrative work. So it's all relative. Great question though. I try to sleep. I don't stay awake as much as Werner. So I don't have 300 publications, you know, but go ahead. 500, exactly. I think he did by stock and Pearl Diver or United Healthcare, you know. So, but,
What's your, the fact that UPMC is so big? Are you responsible for all of those community programs and things as chair? Or
Yeah.
something other
Yeah.
there?
Yeah. So it's a blend of it. So I'm immediately, I'm fiscally responsible. If you kind of look at like, you know, incentives and stuff like that, I'm fiscally responsible for the department, academically to the dean, clinically to the entire system in regards. So when we have access metrics and we have financial metrics, it's the whole system. The department and the Allegheny County element is a heavier weight in that. And then that's kind of growing. So they look at access overall. I have an access metric for the department, for the community practices separate. And that's where we lean on. So our service line now, I've assigned or appointed service line regional, physician administrators, essentially, who are all clinical. No one's just sitting there, you know, finger pointing. And they help navigate challenges at different hospitals. So there's an Allegheny County regional person, an senior executive vice president physician. He's then in North and Erie, there are 2 chiefs. And then in Central PA, there are 2 chiefs. One of actually is one of the private docs. And so it kind of keeps evolving, Dr. Weiss, I mean, to answer your question, because, you know, we had these consultants come in who wanted to know about, okay, do you have surgeon and physician champions in every region, right? I had them already, because I mean, the first several years when our service line was being built in like early 2014, 15, I was doing road trips around the entire state. So I would get in the car with our VP, Freddie would send us, and I would drive to Susquehanna or Williamsport. We would go to Harrisburg when we bought that hospital system, we'd go to Erie. When their residents needed to come rotate with us when we acquired Pinnacle, get in the car, drove over. When they came back over to meet with Freddie and kiss the ring, I was there. So you build, and so that's how that was built. And so now when they ask these questions, I have a list of 20 docs across the enterprise who are the respective surgeon champions for their region. So if someone calls and says, hey, we're having issues with, and we're not perfect, you know, because if you look at the news, UPMC is losing money, probably because we have too many administrators, but that's all good. So everybody's losing money now in theory, but essentially if they call about a certain hospital or a certain region, I'll say, great. I didn't know about that trend, or I saw that trend too. These are the 2 docs you should start with, right? And so I'm working on that of trying to have, you know, not distance myself, but basically put other people in positions to do the day-to-day kind of follow-up. And then we have quarterly service line executive meetings where some will call in teams, some will come on site, but I do faculty meetings with the core academic department and the research faculty once a month. Like no matter what, I alternate them, one in person and then one is on Teams. Yeah.
And you give a dashboard to everybody. What do you do when quality is clearly an issue in some areas that you don't have control over?
Yeah, no, you're right. So I learned medical staff politics very early, but so a couple of things helped us. One, you see this quality there, and you can't go in hammerhead on things. I mean, doctors, we've built a pretty good ironclad protection mechanism. And also the healthcare has too, right? I hate to say we're an organized crime unit, i.e. healthcare, but you don't become 20% GDP by accident. So someone has a quality issue, and all of a sudden that's the nomad. They just kind of bounce from site to site. No one can nothing sticks to them. So we create the quality dashboard. We use our health plan a lot. So we'll pull data, their health plan quality data, because they're in network, and we'll pull their hospital specific data. And then we'll try to go in with one of our improvement. And we've done this sometimes it goes well, sometimes it doesn't, but it puts it on their radar and they know someone's tracking. And so we will then have a quality improvement nurse. Luckily it's them, not just us, because they think we'll kill each other as surgeons. Quality improvement nurse goes in with either our vice chair of quality or one of the surgeons from that region who they have a lot of respect for, right? And that's tenuous. And so every once in a while, there have been times, we had a couple hospitals a couple years ago, I had to, me and like 5 of us, like literally drove in, sat down to meet with some of the surgeons. We did the same dog and pony. We met with all 5 surgeons first, even though only one of them was the issue, right? And we were like, why are we doing this? So we made something that we would do at M&M, which should be like an instant, like I should fire you on the spot. We made a 6-month journey, but I can tell you in that good case, quality improved, they got their COE status, the person knows they're being tracked. Now let's go down the other direction when it doesn't go well. It has to impact quality. And what I've found does moves that along faster than anything is when it is starting to impact medical legal, not necessarily financials, because that's one of the curses we have as orthopedic surgeons. We make tons of money for the system and people don't die that much, right? So they end up in the gray zone. If 2 or 3 people code in the ICU all at once, I guarantee you they're gonna figure out what the hell just happened immediately. Because one, the ICU is probably losing money, right? Everybody's watching it and they don't wanna lose their critical care status. With ortho, we live in this gray. And it's not to say it's a bad thing, but it does make it hard. And then we had one hospital president who was like, well, this guy's making me something, you know, he's doing so well. We pulled up this guy's quality in front of him and said, great, stick with him. You're gonna lose your COE status in basically on this pace, 6 months. He was actually getting an extra financial hit from one of the insurance companies as part of a value-based program. All of a sudden we had his attention because he didn't know it was gonna affect his bottom line. So then he helped us, but it doesn't always end that way. And so that was my pre-chair life. What you just heard me describe, I try to have our vice chair of quality, George Russell, who's on board now, and Bill Donaldson, do that first wave of assessment. Because otherwise, with a system this big, if I'm pulled into every single scenario, I mean, it's just not sustainable, right? But the quality piece is coming. So the hospitals are helping a lot more now because they know it's affecting the reimbursement. So for us, that's really helped us. I mean, we got investment to do a patient reported outcomes platform for the entire system. We're the only service line for that. That's not because they like Mac Hogan and because it was great in my package, I asked for it. It was because they know if they don't actually collect the outcomes, they're not gonna get paid. So all of a sudden now, right, you align the incentives, you start getting stuff. But most of the time you gotta fight for it still. Great question. Other questions? Comments on the madness?
You should probably talk about your memory lane.
Yeah, perfect. Oh yeah, perfect. I got it later. Next. 1 second, Bobby. Hold on. All right. I think, no, I was shutting one talk down and then putting the other one up. So. Yes. Oh, sorry.
Put on the research now.
Oh. So when you describe it as effort, maybe let me, when you describe it as, so I still do a research meeting every week. So it's hard to break it down in effort. And so respectfully to that, I learned that from Fu. So every Wednesday, the research team meets with a mix of our medical student research fellows, the research coordinator we have, and you know what, Dacus? I may need Winston. It's got my computer, but it doesn't have the talk. Let's try this again. All right, back. So med student research fellows, clinical fellows, and our research coordinator. And then based on the basic science studies we have, one of the reps or postdocs from each of those labs will come give an update on what we're doing. now that I've extended the faculty, so Jared Kane is with me. He's a podiatrist, had a very strong research background, particularly in diabetic models and Charcot. And also just hired Pete Mangone. He's going to come in as the new chief of foot and ankle. So he came in, Pete starts in September. So I try to make sure that at least one clinical faculty is at every meeting. I try to make every other one. And then if I miss the meeting that week, the research fellows, some of them will be in clinic with me or they'll be enrolling people in studies. They'll just give me updates. And then they do a PowerPoint for each week. So even if I'm traveling, so they're meeting today, for example. And I base sign on at noon while I'm in the car, but if I don't, they'll kind of log that. And now, again, it's imperfect. It's getting better, but I learned that from FOO. So every Wednesday, FOO's research meeting would have like 50 people in the room, and they would come in, and it's basically every lab he was working with. And that's why when people used to debate him at meetings, I used to say they have no idea. Like, this guy has a small Santa's workshop back at home, basically studying everything every second. You can't compete with this dude. You can compete, but you're not going to win an argument, because he would basically bring his whole team back, have them research what your basis of your argument was. And if it was good, he would say, okay, you're not so stupid. That's how he would lead with some of his comments to people, right? But it was the research team each week just feeding the beast. So I still do that. And then, it's still at before and after hours, so things happen for you. I do try to stick with what Miller said, make your own talks. So I try my best to make my own PowerPoints. So it's never a scenario. They may pull slides together for me, for example, but I never actually just present something they have like as the only thing. One, because I don't want to be embarrassed, like, oh crap, what was that? Two, I want to know what's going on. And to do high impact science, you have to pay attention, right? The people who get in trouble is all of a sudden you look up and they're like, did you know if this guy was plagiarizing, or this data looks horrible? So that's what I do now. So once a week. And then we have a research meeting every month where we actually, I do my best to attend those, because, our research faculty, they want to know you're invested as the chair. So I do those are Monday afternoons once a month. So I've stacked my schedule like this. Every Monday afternoon with the admin day, and I will probably change this 35 times over my career. Every Monday is some type of administrative meeting to end the day, because that's the day I'm I'm fresh for the week. So second week of the month, executive committee. Third week of the month, research committee, the research meeting. So I can attend 5 and 6. Fourth Monday of every month, faculty meeting. And then the first Monday of the month in the morning for an hour, I meet with like the executive committee on the executive committee, basically the small cohort of, faculty who are going to help deploy the madness. And that's the department meetings. That doesn't even count so it's a lot of meetings, but you got to make your meetings effective. Everything has an agenda. Everything has very short time periods, 30 minutes, 45 minutes, hour max. And so I've become the master of the 60-minute meeting. Like, if our meeting goes longer, I'm going to warn the faculty before and say we have an extensive agenda because we have XY guest, the dean, right? People are not going to complain about an hour and a half meeting when the dean shows up. Other than that, 60 minutes. Service line meeting every Thursday, fourth Thursday of the month, alternating in-person teams. And if nothing to talk about, I have no problem canceling a meeting. I say, hey, look, we have no major updates. We've all talked. We've already met in 1 year, more than Freddie had meetings in a lifetime. So you know what? It's enough meetings. We're canceling it. If you have a problem, call. That's kind of it. So a little memory lane. So a couple of things. Environment does matter. So I think this is very important. So when we talked about research and culture, the environment here did matter. And I did get this from Cato as a chair thing. So all of us have quotes, and we'll have a little fun for the next 30, 40 minutes. But Lorenzen, like probably 15, 20. Lorenzen used to say, problems that go away by themselves come back by themselves, and usually when it's least convenient. That is very true. So each time I've kind of kicked the can on something, it may not come back to bite as much, but the bite is definitely more than it would have been if I had just taken care of it. So I'm still working on this, like, just deal with it now. But that's also what locks us in. It was BlackBerries when I was a resident. I mean, when I was a resident, the iPhone was invented. I remember it came out like 08, 09, and everybody was fascinated by it. But, you're constantly locked in. So you almost have to force yourself to separate, right? So Mindy, the first memory lane. So I tried to find, I don't know if Mindy's in here. I saw her yesterday. I tried to find Mindy. I talked to her yesterday. I tried to find a picture of her, like a new one. She's like me on social media, like non-existent, like very subtle, underground. Like, I don't have a Facebook page, which is probably unpatriotic at this point. I don't have any page other than IG and LinkedIn. But Mindy was the den mother. right? Which it sounds like it's still the scenario. So when she gave me the tour of you guys' space yesterday, when Charbel brought me over, I was just like, no. So just so you guys know, the word on the street from the alumni is these guys got it sweet, right? Because I go over there, I see those 2 monitors. I'm like, oh. So I said to Mandy, I was like, oh, did the chief residents get the double monitors? And I didn't realize that everybody had a double monitor. And she was like, no, they all get a double monitor. I was like, oh, I was like, how do you do seating? She's like, well, most of the chiefs pick a window seat. I literally was like, oh, kind of nice. I was just excited to get invited to the attendings house for Journal Club. But the goal is for your experience to be better than that of your predecessors. And last I checked, it absolutely is. And if it is going worse, it's definitely, I mean, that's a sweet setup. So I'm happy for you guys. And even when the faculty seem like they're the worst thing that happened to you, you know, a thank you every once in a while is actually okay. All right. So Mandy was a dear mother. So here's where it gets fun. So Abel and Dr. Rahman. So there are some people who I've left out of this because they weren't faculty when I was faculty, but I still got good stories. So Abel, when he became chair after Cato left and he and Dr. Traub were running the place, all I remember him being in clinic was like no breaks. It was the most painful, one of the most painful clinics on the planet because you're trying to do these Scoli neuromuscular assessments and Abel's yelling at you, no breaks, Mac, no breaks. I mean, you're just like, dude, like lean off me. And you were basically, you're going next door, you know, to actually do, and you're running cast clinic at the same time, fracture clinic, and you're molding people. And I literally, I mean, but he made me a better resident. I was a chief resident like a month before graduation. And I think I came to clinic, the intern was there, IGPAY, of the second year. I come to clinic like an hour late from rounding in the hospital. And he pulls me aside and hounds me about it. He's like, I expect better from you. You know, you should be more responsible. You got this kid here wailing. And he'd be like, now get started. And just remember, no breaks. And so you knew you weren't going to get lunch. Lunch was like an afterthought. It's not like I needed more food. And Abel knew it. He's like, so, but he was a great teacher. And I just remember having a lot of fun having conversations about Louisiana because he grew up there and, you know, the bike riding. And then I don't know how you guys do Journal Club now. Is it still at different attendees' homes? So you got a problem now, though, because you got way more faculty. So, you know, back then it was almost a competition of where did the residents want to go for Journal Club? Like who's how. It was the one time where the attendings were subtly competing for you. Like, oh no, you want to do Journal Club in my house, right? And Abel would do like an opening barbecue where you go to his house and, you know, we had that. And then after that, you know, Ramnes had one of the best because he would do these Scotch tours. And so I learned about Scotch, to capitalize that, from Mark Ramnes. Like just, you know, you didn't think I remember that. And like these bourbon barrel, you know, these Scotch barrel tours. And that's when, I mean, you just stay up all night at these attendings' houses. Their spouses probably wanted you to leave. It probably still happens. Is that what you guys still do? You still do it at houses? Are you still allowed to do that? Nobody complains about it. Oh, good. So you guys don't just complain. I'm just picking on you because I have residents too, so I know how it is. So everybody's still. So how do you pick the attendings? Residents pick, or you just tell them where they're going?
Been chair for starting 12 years. I know when to keep.
Yeah. Just stay quiet. Yeah, stay quiet. So foot and ankle. So this is going to tie into White. So when I started, I couldn't find a picture of Francisco Casedo. You guys can appreciate this, but Joe Park, Dr. Hurwitz was who we started with, and Dr. Hurwitz, respectfully, you know, I still tell the stories of your clinics because, you know, when we could do bone biopsies on the floor, he'd be like, just go get a rongeur down from the OR, just go up to the floor and just, you know, warn the patient and just get a little bit of bone. They're not going to feel it. They're neuropathic. It'll be fine. And so, and this didn't come directly from Hurwitz. This came from your chief resident because he was like, Dr. Hurwitz was going to expect us to get a biopsy, to get a tissue sample. You're like, really? So you go down there and there were all of these foot and ankle rongeurs in single peel packs, sterile peel packs. You go get one, specimen cup, biopsy on the floor, take it back to the lab. Frank's nodding because he remembers doing that. And when you were on rounds, hey, those were the only people in the hospital. Anybody else was there. They didn't, I mean, it was outpatient. And then Francisco Casedo was here, but he left. And then Dr. Park came, Joe came then, and we'll get to the be careful, be careful. So be careful, be careful. And then it was deep breathing. And I'll tell the story of this, which ties in. And then he's like, just practice more. And like I said, Dr. Hurwitz just said, get a walk on water, letter recommendation, you'll be fine. So then trauma, right? So and respectful of Dr. Kaler, who, you know, his unfortunate passing. But I remember you'd be on rounds and nothing, when you would go in and see a hip fracture's on, he would say, you know, this calls for a good old fashioned DHS. It was always like the DHS could treat everything, which is pretty true. I mean, and he was, other than the subtrope, he knew it, you know, he's like, yeah, this was not gonna be a DHS. This one needs a nail. But other than that, it is a good old fashioned DHS or a Hemi. Like, it was none of this doing total hips for joints then. And I remember Dr. Weiss when he came, you know, after he did his military time, and we would go to an ankle fracture. I don't know if you still do this, so if he doesn't now, but he shows up and, you know, we're putting all these self-retainers in, stretching all the soft tissues, and he'd be like, take those out. No self-retainers, you don't need those. That's why the wound's gonna break down. And, you know, and so everything was like small home ins, sins, and so I still practice like that. And so the residents show up on my service, and I come in, I go scrub, I come in, and they've got these self-retainers basically stretching someone's fibula wound from literally, from toe to head to toe. And I'm just like, take those out. I was like, and I tell them, you know why I'm not on the M&M list for infections? Because I take the self-retainers away from the residents. You have no idea how much, and I learned that from Weiss. Like and it's true. They're like, yeah, you're not on the list much. And I was like, yeah, when you're the chair, you're the program director, everybody wants your stool to end up on stage. And I was like, so I got to work to keep it off stage. But self-retainers, we'll talk about the K-wires in another visit. But I've worked with a lot of Harborview people. His K-wire load is nowhere near what is really out there. You'd be surprised. Like, so you're working with a master. Yeah, you always add more, but you're working with a master. And so there's a good story, and Joe will remember this. To let you know you go a long way. I'll go to spine in a second. So when when Hurwitz was here, he left. And my 4th year foot and ankle rotation, I'm going to foot and ankle. I'm really nervous about it. Dr. Park's here, Joe's here. And so you just want to do a good job, right? So I've done a good job with all these other rotations. You want to do a good job. You're all, you kind of your sphincter's tight. And we started, and we would do these brostrums. And literally Joe's probably like, holy shit, I remember this. Like, we had like a run of like 4 or 5 cases in a row where I was basically pulling out knots and popping knots on the suture. You remember this, Joe? He's like, I didn't want to remember it. And so, I get ready to tie it down. He'd be like, okay, be careful, pop. And literally it would be careful. And then he would just go deep breathing. He would just walk around the room. It's like, yeah. But he never put me out. And I remember I'd go home, was like, fuck, I'm literally losing my shit. I'm like, man, like, why do I keep popping these suture anchors? And then this is how and the only reason he didn't put me out, because he was getting good counsel from probably Dr. Weiss and the rest of the faculty, because I'm on call like 2 or 3 weeks into this. I'm kind of down on myself, like, oh man, like I can't, like this is not going to work out if I can't freaking square, get my knots and stop popping suture anchors, right? Luckily, you couldn't see them on X-ray, but every anchor you had to re-drill it, redo it. And anyway, I still remember Dr. Joe walking around the room. So I'm on call on a weekend with Dr. Weiss. We're doing a fracture, and like, he was very subtle. He's letting us do the case. He's like, hey, Mac. He's like, yeah, and you may not remember this, but just and I'm like, yeah, Dr. Weiss. He's like, yeah, I hear you're not squaring your knots on those suture anchors. And I'm thinking to myself, these guys are talking shit about me behind my back, right? And he's like, but he's like, look, just take your time, square your knots. He's like, just relax. And I remember, but that was the counsel that Weiss and all the faculty were probably giving them, like, it'll be fine. But I popped probably 3 or 4 anchors. It was like brostrum after brostrum. And each time it just kept getting worse. And in the end, so to that point, it is the most important part of doing the brostrum with my residents now. And I tell them the story. I was like, look, when I was popping these anchors, I said, you will pull this out, or you will basically you will break this knot. And next thing you know, we got to redo it. And so my residents still know that story. So, and I tell them regularly, like, this is the most important part. You will destroy this repair and we'll have to redo it. So I don't drop that many expos in the OR, but that's the one time when they know I'm just paying attention. And that's from experience, but luckily, Dr. Park still let me operate with them, and they let me graduate. So spine. I don't know how, some of these pictures, I just couldn't get good ones. Did they know, was Whitehill, do any of these guys know Whitehill? Does he show up much?
No.
So a good story. So when I was here at spine, I'll tell the journey. So this is a good one. So Vince Arlay was the chief at the time in the beginning when I was here. And Dr. Sharma came when I was a PGY3. And I was Dr. Sharma's, I always like to say, I was his first chief resident because we shifted the rotation to where the PGY3 was like the more senior person at one point. I don't know what it is now. Whitehill was slowing down, and Arlay was always angry that no one was going in the spine. Remember this? He was like, no one wants to do spine. No one wants to do spine. The residents need to rotate on spine earlier. They were, second year with Frank, third year, with like, it was just be on spine more. And so it was like more residents need to go in the spine. And I just remember when Sharma showed up, right? We were round, and then you'd be in clinic, and you'd be like, it's just so much back pain. Because he was just so much, it has so much back pain. And he had just come from Rothman, where these guys basically had a feeder mechanism for operative things, and all these people would show up with back pain. And I remember thinking, like, I don't know what they told you about this place, but it's going to be more and more back pain, but luckily he knew we're coming here. And then you can now I read. They already signed. It's already signed. Yeah. Dom, what's up, man? They already signed. And so we were talking about the back pain. We were around, but now I see also what you had between Rothman and also Pitt. When I got to Pitt and Kang had this factory of surgery, I'm like, okay, this is why Sharma was like, wow, all this back pain, because it's basically like everybody who walked in there was getting the surgery. But to Dr. Shin. I don't know if it's still I hope it's still not like this, but he was the one person you couldn't beat in the hospital around. You couldn't beat him. So you would show up at 4:30, and you come around the corner, you think you're ready to get your list together, and you see someone basically hidden behind the computer, looking at images, and it's Frank. And you're just like, how did he beat me here, right? And then he would send you, Winston remembers this, he was one of the last of the Mohicans, and he would send us to get the printed CT Milo for every patient. Every slice, Werner's probably like flashbacks, every slice, and he's like, go get, and you would go down there, and the imaging specialist would be like, why do we keep having to print this for you guys? Whether you're the only ones who requested, this is terrible. They would try to make it seem like the machine was broken. You would come back, he'd be like, just make sure you have it in the OR before the case starts. And so you would go back again. Remember these packs, you probably can't do that anymore. It's probably against sustainability laws, but, and so he would just send you down to get the CT Milo. And then anytime you really felt the suffering, he would just say, just remember, you get to rotate off of my service. That was Frank's line. And then he would take you to lunch down on the lawn on, downtown, and we go to 10 and he talks to you about life. So I remember that. And I appreciated that too, because he always took the time for us, even with his family. But to Dr. Whitehill, a number of you don't know this guy, but he's a great sculptor. A number of his, and we were fortunate. He was also like able. You feared him a little bit, very respected. And he had a lot of great advice about academic career. And he didn't talk much, but when he did talk, it was very effective. And at that time, there was this tradition of running with him, because he and Abel were runners. Abel would run with him, and Abel also would bike, but he was a runner. The chief class before us, Winston remembers, they stopped running with him. They just said, we're not doing this anymore. Because it was a thing where everybody ran with him, whether you were a big, small runner. I mean, you could be a quad and you were going to run with this guy. And he only had one. And so one of our bright ideas was, we're going to bring back running with Whitehill. We're going to do it. So you rotated with him on one day a week, and you would do some cases with him. And then you had a half clinic. And that day with the half day clinic, you could go run with, you would go meet him in his house, and you would go run with him. And our class did it. We made it through the year. Everybody said, we're going to run with Dr. Whitehill. And I just remember him saying, he used to call me, because everybody called me Mac. He used to call me Fleetwood, for Fleetwood Mac, for the band. And he said, I don't care what you do, Fleetwood, just don't stop running. So he would tell you when you ran with him, he's like, look, he really would say that. I don't care what you do. He said, just keep moving. I don't want to catch you walking. He said, I would rather you pass out than to stop running. So you literally just kind of be like, I was just doing a little hop skip. But he would say that. And so I ran with him for 6 weeks straight. I have him on the rotations where every other week when he was in town, you ran with him. And I was in the best shape of my life. But that was my spine experience. Hands. So this was great. So Dr. Deal came and joined us, which was great. We talked about research life. She in the OR, she'd be like, take your time. It's going to be fine. Aaron Freelick, is Aaron here? No. Yeah, so Freelick was he was my chief resident, and he started as I was a chief, so it was kind of great to have him come back. And you know, it is an interesting thing when you're actually working with people that you trained with or trained under, and they're your faculty now, and that's hard too. That's not an easy journey to make when you have to come back. Winston had to do that, and Chauber did too. But he also would say, how did this become our problem? Because you can really conspire with Aaron together, like, you know, how did this become our issue? So economy of motion, you're like, who said that? So in the OR, I'm hoping Dacus still does this because I still tell my residents this. You know, you get ready to do a distal radius fracture, you bring in the mini C-arm and you do like 35 x-rays before you even make a decision. So he would come in and be like, why is the mini C-arm in here? Like, it's like, we're gonna be looking at it in a second. That's when we bring the C-arm in. That's when we take the C-arm out. And you're like, well, I just wanted to kind of get my landmarks. He was like, you know where the hand is, don't you? He's like, so he's like, you're wasting time. He's like, economy of motion. That's the only way you're gonna get in, get done. He's like, and you got to keep moving. And these guys were like masters of that. They were like, you know, him and Bobby, they're like, yo, get that C-arm out of here until we need it, right? So I tell the residents now, like, don't take 3 million pictures. Start work, get your work going, then bring in the imaging. So each shot you take means something. Each movement you take, and I'm still not a master at it, but economy of motion, my residents hit a lot. And so Chauber so there's a very interesting story about how going in foot and ankle, the injury had interest in foot and ankle, but I had not told Chauber yet that I was not. At one point, Hurwitz and Bobby know this, I was thinking about doing hand and foot and ankle. I was going to become, you know, the Jim Nunley, Bob Adelars of the world, and I was going to do a hand fellowship and I was going to do a foot and ankle fellowship for 6 months. And then eventually, because you had to do the full year of hand because, you know, these hand people and their CAQ, and I was gonna do 6 months of foot and ankle because I love tendon work. You know, I like nerve work a little bit. I didn't like micro that much, but who does? We were at a meeting at the academy. Bobby remembers this. We were at the Gladden luncheon. And at the luncheon, like one of the people up there, like one of my other mentors from Howard was like, you know, and Matt Hogan's here I was a resident board member. And, you know, he'll be applying to foot and ankle surgery next year for fellowship. He just says it like out to the whole crowd. And Chauber looks across the table at me. He says, you are dead to me. Literally. And he was just like, we're going to talk as soon as we get home. Like we get back and that is converted over time because look, we did so much work together and he's like, whatever you need. And that's how it's always been now. So if I call him, you know, he's the #1 chair on my speed dial with drama, but also with just, you know, how are you doing? You just kind of shoot a text. And he would just say, whatever you need, brother, I got you. But I remember, because I hadn't broken the ice to him yet. And I was just like, oh, this is going to hurt. Like, because, but anyway, I probably should have just told him before. It would have been easier. But so joints, this was good. I know Tom Brown retired and, you know, he was great. The way it was set up with joints at that time, you had these certain rotations. So this was the fleet then. And you had these rotations and Tom Brown had a day, I don't know if he still does, well, he had a day where no one was in the OR with you as a PGY2, but you and him. He had one day where he would run one room and put on 2 to 3 knees and that was it. And he would do clinic and you would do, and then one day you knew it was coming like every other week. And it was pretty much, couldn't call the fellow, couldn't call the chief. Like it was no PA, it was just you and Tom. And he was pretty much like, all right, we got these total knees. Do you know the steps? How are you with the saw blade? And, you know, so you were nervous about those days because you couldn't hide anywhere. It was pretty much like, if you don't know what the hell you're doing, it's going to show. If you didn't read, it was exposed. And, but those were the days he would check people off on big bone surgery, right? So you get through the end of them and he's like, it's just you and me, let's go. And then if you did well enough, he'd say, I think you're good with big bone surgery. You know, so, and then he also gave a good lesson. So we were here as 4s and 5s when the anterior hips really started to take off. After the metal hip failure, I was also a resident during that period. But when Tom was converting to starting to do anterior hips. And I remember, you know, in retrospect, you're in the OR with this guy who you have like the ultimate respect for is, you know, master surgeon, can replace or revise any hip or knee. And he's just in the OR, like, WTF, why am I doing this? He had to change his exposure. You know, he's reorienting himself to a joint he's known his whole life, right? And the courage it takes to do that. And I just remember being with him and something was crazy with a retractor. Why am I doing this? And all of us do it. You find ourselves like you can't stay the same. It's almost to the point that Fu made, right? And if the environment evolves around you, your ability to adapt is what's going to help drive your career in a successful direction or a painful direction. There'll be enough pain on its own. So, find the ability to adapt. And these guys all did that, and then he would just say, if you effed up something, he'd be like, so Trey, he would just say, don't worry, Mac, just practice and read. He's like, just practice more and read, and Trey was like calm in voice. So JB, he had just started when we were here, he looked just as good then as he does now, perfect in a photo, right? Intentful. But when I was interviewing for Foot and Ankle Fellowship, I went to Duke. And anybody here from Duke Med School? Nobody here a Duke fan? I know his kid goes to Duke. Nobody. So we have no Duke fans here, Duke neutral. All right, fine. All right, that's fine. So I go to Foot and Ankle interview and Nunley's the chair. And Duke didn't really give direct messages. They gave all these indirect code messages. It's like the movie Skulls. It was weird. So I'm in clinic one day and all I remember is, JB walks down the hall, he leans over to me, with his hands in his pocket and his perfectly tailored sports jacket. I mean, he looked like Brooks Brothers, like it was perfect. He leans in, Nunley wants you. And he just walks off. And I was just like, what is that supposed to be? Is it like a command or something? It was so odd, right? And I joked with him about this and he was like, so I'm going to say, Nunley wants you. And that's it. And it was almost as though the comment had self-destructed as soon as he said it, right? He would never admit to it after that. And I was like, oh, okay, but no, we learned a great deal with Dr. Brown. And as you guys know, we're the department that has every division had someone with the same name or same last name. It was very odd when I was here. It was always, but now sports. The stories are more than I can count. I think Dr. Didak had to step out, but so when I was here, Miller was the chief, Carson was one of the associate PDs, I've got Dr. Didak and Dr. Brockmeyer came on board, and Werner was one of my junior, you were a year behind me, right, Werner? And he left, he's in 6-year track. And I do believe he does have stock in Pearl Diver, and he stopped using it as soon as the stock sold. So I told him that earlier, so I'm not making fun of him. So, he was the legacy, soon to become Werner at that time. So Miller found out I was going to Foot and Ankle, and I remember he was like, you're going to hate your life. You're going to hate your life. Like, why would you want to do that? It's nothing but pus and foot, and all this. And at that point, we had a decent relationship. And I said to him, I was like, well, Dr. Miller, what's your excuse? And he was just like, good comeback. He's like, but you're still going to hate your life. And so we joked about that. And he would just say, you start a scope with him. He would say, show me the pathology. So when you got into, if they had a medial meniscus tear, a lateral meniscus based on the imaging or exam findings, he wanted you to show him that, like show him that first and go in it, attack it, address it. And then you would go look at the rest of the joint. But master arthroscopist, learned a great deal with him. Didak was like master surgeon too. And I've got another sports story here. So he would say, you mind if I take a look? So you kind of sitting there, you're scoping, you're feeling good. You're like, okay, I'm in the driver's seat. And he would just kind of be like, yeah, great, Matt, great. Mind if I take a look? And before you knew it, it was like, okay, I'm done here, right? I mean, it's over, but he would allow you to kind of get your hands in deep and make it. But it was always very subtle. It's never as though he really took it from you. It was just like the smoothest handoff ever. And you just kind of like, what just happened? Like, I thought I was actually about to do it, but he was great. And so your goal when you were the third year on service is if I could just get through the partial meniscectomy and he lets me do it, I know I've actually achieved, like that he trusts me enough. And so that's what you really you strive for, like that moment. With each attending, it was a little different. So, also, Dr. Didak used to do total knees. So the Wednesdays, he would do total knees. I can't remember. Wednesday, I can't remember if it was Wednesday, Thursdays. They're relevant to this. But the question about how did I get out of here and not become a sports surgeon? So one day when I was a PGY3, I was with Didak in the OR, and he also was just so subtle with things. And he said, yeah, we really should maybe start thinking about, where you may want to go to fellowship and places you're thinking about applying. I'm not really sure what your, game plan is, but there's some good, places. And I said, oh, well, thank you, Dr. Didak. I said, I'm going, I'm planning to go into Foot and Ankle. He said, oh, you're not going into sports, right? And it was like this awkward pause. awkward pause. He was like, disappointing. And he just walks out of the room. Like he literally just leaves subtly. He's like, okay, great. And again, he'll probably remember that if he was here. And that's literally how the conversation went. It was like, oh, really? Not doing sports? Disappointing. Silence. Like gone. And you're just like, all right, I think I could pick myself up off the floor. But that was fun. So Brock, so you'll appreciate this. So when Steve came to join us, again, courage, right? You change practices, you leave a place that a lot of people, are like, how do you do that? And he comes here and he's, shoulder practice exploding, reverse total shoulders are just like coming off the press, like all these different stems. And I just remember, when we would, and you remember this, I told a story. Remember that night you had 2 rooms and your kid had a recital. and we knew it was gonna be a busy day, but we were like, no, we can make it. We got 2 rooms, we're going good. We got a team here. It's a fellow in one room, I'm in another room. And it's nothing like when you just feel like the environment and the world is just fighting against you. Like it is literally like a cloud. And you're just like, they don't want me to make this recital. They don't want me to make this recital. They don't want me to make this recital. And then they drop a retractor, a tray's not sterile. I just remember one of these moments when you're just like, and as a resident, like, oh shit, we're not gonna make it. Like, there's no way we're gonna finish this. where we're gonna, and I just felt, I learned from some things, but I just felt so bad for the situation. Because and I have wife and kids, and I'm just like, and I remember you asked someone like, what time is it? Because we were locked in. And they say the time, and it's literally like 5 minutes before this recital is about to start. And you say, you're like, this is not happening. And he literally just takes a pause, and he just says, okay. And you just kind of reset, and you're like, hopefully my wife and kids are there when I get home. It's like, but it was like, but I remember this, and I was just like, it's nothing like that. And that will happen to you in life, right? So you try to find a balance. You're trying to find a better half that'll give you a pass from time to time, but I never forget that. Like everything was going well the first 2 cases, so they sneak you into comfort. You're like, oh, this day's gonna go great. And then bottom falls out. And you're just like, there's no going back. But and Carson was the master of teaching you the things you should do and also that you shouldn't do. He'd be like, Mac, don't, and he would just call you. Like if like Bobby was upset about something when they were the PDs together, he would just call us and just say, you can't do that. Like that. He's like, people get fired for stuff like this. Like he would just cut to the chase. And you're like, really? Fired? Nobody fires residents anymore. He's just like, okay, keep trying. Like Carson knew what convention could get you cut off. He taught us a lot of other stuff. And I had to put word up because I know he's crushing it. So again, find your goal, know your goal, own your goal. Yeah, it's a good time. The path will come. So, but it's not about you. I think you have to remember that. And that's what I learned a great deal here. It's about the team. But you have to be about it, right? And as a chair, leader, whatever you do, and just in your practice, you got to care about people and care about others. So, but remember who in the crowd you do it for the most. And so we keep talking about my wife and kids. So when I was here, that's my wife, Danica. This is us at, the historical place of Jefferson's home. And a lot of people don't remember when my graduation day, my wife, she was pregnant and she essentially had to go to the ER. She was like 8 months pregnant, and she had to go to the ER that morning because she had this horrible, she was first trimester, and she had this horrible pain somewhere in there where the baby's big enough. I obviously didn't do good at OB. But we're in the ED the morning of our graduation, like, holy shit. Like, is she about to go into preterm labor? We didn't even know the sex of the kid. It was crazy, right? And so as a, ultrasonographer and women's imager, so they say, well, we can tell you the sex now if you want to know. Like, it was literally, so our first ultrasound together of knowing what gender baby we're going to have was the morning of my graduation with my wife in horrible pain, which they addressed. She didn't go into preterm labor, and my wife is the one who said, oh, we're having a girl. Like she looks up, and so that's our UVA story. So this was my family when I came in 2018. I pulled this from the 2018 alumni weekend photo, and this is the girls then. Tungsten, I still have the bulldog. My wife still hates him. But the only reason we keep him is because he was the first puppy of Monica, my oldest. So he literally will be with us until he dies. His face is like all white now, but whole nother story. But this was in 2018, which is scary, right? Kiana was 2, Monica was 4. And this is them over the years. This is like 2 Halloweens ago. This was the first So our kids were so happy with COVID because mommy and daddy were home the first period. I mean, they didn't know what to do with themselves. So this was, we found some creek that we didn't even know existed. And we had been there like 6 years and we found it because of COVID. These guys and my wife ran track and cross country at the U. So she's a proud fan. It's grown. So now they're bigger. They ride horses against my advice. I'm not a big fan, but you know, your kids do what they want to do. They're both junior black belts now. Danica still tolerates me. This is the sneaker ball that I went to with them a couple weeks ago. So things are going well. You know, we're blessed. It all started here, and I'm an all-in girl dad. My wife hates football. She hates going to sports other than track meets. She despises it. And so now, you know, you get certain gifts, right? So my kids love going to games with me now. So when I started working with the Steelers, they come, and so now she has to come because they're too young to be in the stands by themselves. And so she still complains about it. She's like, and my daughter started liking football, and I hate going to football games. So, but they're only 8 and 11, so she's got 5 to 6 more years before I can send them by themselves. So she's locked in. So now they get to kind of hang out, and you know, it's kind of cool because they're like, all right, daddy's not just a douchebag who's not around, right? We can go to these games, and so it's a blessing. And I put this in. So a couple weeks ago, I was supposed to I was going to Georgetown to work with Bobby's brother-in-law to get the OREF talk. And this is what happens in the thief of night, right? I forget about this event. My wife does too. And I'm like, oh yeah, okay, I'll see you guys when I get back. And my daughters are like, aren't you going to the sneaker ball, which is the next day? And I literally was like, holy shit, right? Years ago, I just would have gone. And I called Jay and I said, look, I need to miss dinner. It's this sneaker ball. My kids have planned it forever. My wife and I forgot about it. And I'll come in the next morning. And he was like, no problem, right? So you do what's right for your family. And it's a memory they won't forget, right? So with that, thank you. And it's great being home. So that's it.
Thanks, Mac. You really mentioned about embracing our past, and you really shared a lot about this department for a lot of our residents. And we've had 12 faculty join in the last 3 to 4 years, so a lot of faculty don't know our history. And to review that, that's really remarkable. And thanks for sharing your story and all your success and how you really made research a part of your career and one of the biggest reasons of your success. Congratulations on second year as chair there at one of the most storied programs. I can tell you one thing was very gratifying for me to hear this talk, first time I've heard this talk, but you know, as a faculty member here and as someone who has helped mentor you, many of people who have mentored you, it's so gratifying to see the success of our graduates. And you know, you talk about legacy. People think legacy is a building or your name on a building or something like that. Your legacy has nothing to do with that. It's about the people you influence, the people you mentor, and watching them succeed. So we're very proud of you here. Proud that one of our alums. You're a great role model to our young faculty and to our residents and fellows. And thank you for coming back. Got a lot of swag for you. I know Pitt's in the ACC, but you're going to have to wear this around. Thank you very much for being here. So.